Hello, I'm Dr. Jonathan Leffert. I'm a clinical endocrinologist in Dallas, Texas, and the current president of the American Association of Clinical Endocrinologists. With me today is Dr. Vivian Fonseca from Tulane Medical School. I'm going to talk about innovations in basal insulin analogs. First, I'd like to talk about the current basal insulins available. If we start with NPH insulin, which is a very old insulin, that insulin had a fairly short onset of action and a fairly short peak. It usually lasted about 10 to 16 hours. The big advance was when we went to basal insulin glargine, U100. It was a long-acting insulin. It did not have a peak. It lasted up to 24 hours and had a half-life of around 14 hours. Then we also have another insulin analog called insulin detamir, another basal long-acting insulin, also with a relatively flat peak and can last up to 24 hours, although sometimes one has to take more than one dose of insulin detamir a day in order to get control of diabetes. And then the newest insulin is the follow-on insulin glargine, which has no pronounced peak and also a 24-hour duration, similar to insulin glargine U100. Another insulin which has been recently introduced is insulin glargine U300, which is another long-acting analog. It has a very flat peak, can last up to almost 36 hours with a half-life of around 23 hours. And the newest basal insulin in our armamentarium is insulin degludec. It has a short onset of action with about a 25-hour half-life, and it takes a couple of days to get to steady state with that insulin. So in summary, in the evolution of basal insulins, we've gone from a short-acting insulin requiring several shots a day to long-acting insulin that requires one shot, possibly over at least 2 to 3 days. In looking at another recent addition, we have Basilar, which has recently come on the market. And in comparison to glargine U100 in insulin-naive patients, it was shown that hemoglobin A1C, insulin dose, weight gain, and hypoglycemia are essentially identical between glargine U100 and Basilar. Dr. Fonseca, would you talk about the ultra-acting basal insulins, please?
So we now have these ultra-long-acting basal insulins, U300 glargine and degludec. U300 glargine is actually nothing but glargine itself. Same molecule as the U100, it's just made more concentrated. And when you make it more concentrated, it lasts longer. It has something to do with changing the pharmacokinetics because it's a smaller droplet and it's absorbed slower. Degludec, on the other hand, is a different kind of molecule. It's an analog with some substitution. They're both designed to work longer than glargine. So they also, as a result, are flatter in that they have less of a peak. Their half-lives are like around 24 hours, degludec being a little bit longer than glargine. And although the time to steady state, as you pointed out, is 2 to 3 days, which means we have to wait a little while before making changes in dosage, and the effective duration on pharmacokinetic and dynamic studies is longer than 24 hours, up to 42 hours with degludec. They're really given once a day in clinical practice, because if you try to do it longer than that, it doesn't work that well for getting good glycemic control. So that's what we've learned from studies. They're longer acting. There haven't been head-to-head studies between these. Most of the comparisons have been with either detamir or U100 glargine or with NPH. So if you look at the pharmacokinetics, here's an example of comparing U100 with U300. Exactly the same molecule, but the U300 has less of a peak and a longer duration of action. What that means in practice, less of a peak means you're less likely to get hypoglycemia at those earlier time points, which might be important to patients who get hypoglycemia during the night. And as we see from clinical trials, that has actually made a difference in trials. So speaking of trials, let me first of all talk about the U300 trials, where the comparison was made between U300 glargine with U100 glargine. And these studies were done in type 1 and in type 2 diabetes separately. The program is called Addition, and in type 1 there were 2 studies, Addition 4 and one in Japan called JP1. There were a number of studies done internationally and also in Japan separately in type 2 diabetes, encompassing a wide range of patients. In type 2, there were people who were previously on basal bolus therapy. There are studies in people who were just taking one basal insulin before. And also importantly, people who had never been on insulin before, failing on oral agents, starting their insulin, answering the question, would it make a difference whether you started with U100 or U300? And Jonathan, what would you expect? A difference between these? It's the same molecule.
So in actuality, Vivian, there wasn't much of a difference at all. If you look at the data in terms of hemoglobin A1C over the period of the study, the U300 and U100 essentially were the same over time.
On glucose?
As far as glucose is concerned. And also on fasting plasma glucose, it was essentially the same between the U300 and U100. But if you look at the issues of a few other issues, weight change, it turns out that the U100 insulin, you gained a little bit more weight with U100, and in terms of the insulin dosage, you required more insulin when in the U300 arm of the trials. So that's something again to think about in clinical practice when you're taking care of patients with diabetes, to think about maybe up titrating the dosage in patients who are on U300 as compared to U100. Also, the major issue though is the issue of hypoglycemia. And if you look at in the studies between glargine U100 and glargine U300, there was a significant 48% lower incidence of hypoglycemia as defined by a glucose less than 70 milligrams per deciliter in the patients who were on U300 as compared to U100. This is a significant issue and is very important in relationship to taking care of patients on basal insulin, because hypoglycemia is what prevents you in large part from improving their glycemic control overall.
And much of this difference is seen during the night, isn't it?
Yes.
Nocturnal hypoglycemia, which is very distressing for patients.
Yes. Vivian, would you talk about the other new insulin degludec?
So insulin degludec has a wide range of studies. They called it the BEGIN program, and again, they did it in type 1 diabetes and in type 2 diabetes. And the program is a little broader than what you just described with the U300 insulin, because it's a relatively new insulin. In type 2, they used it in people just starting insulin for the first time, on people already on insulin. And they also have 2 strengths of the insulin degludec. There's a U100 and a U200. So in order to be a little comprehensive, they carried out a number of clinical trials. The bottom line is insulin, and when you're comparing degludec and U100, in terms of glycemic efficacy, as you just heard when you compared glargine, U300, and U100, exactly the same thing happens when you compare degludec and U100. You have the ability to titrate, and you're titrating to a fasting glucose. You will end up with identical fasting glucose, and when you do that, the A1C is also identical. So all these insulins work to lower glucose. They work equally if you titrate enough. But there are other subtle differences start appearing. At least in the degludec versus U100 glargine studies, there was no difference in dose. There was very little, if any, difference in body weight. The striking difference comes in hypoglycemia, just as you saw with the U300. And I think this is very important for patients. There's one important thing to remember, though, and that is the definition of hypoglycemia. So could you walk us through this? I think they used different definitions in different studies and got different results.
Right. So if we talk about the hypoglycemia in the different programs, there was the degludec and glargine U300 versus the glargine U100. And in a meta-analysis of these phase 3 clinical trials, a number of different studies basically showed with the definition in the degludec trials of less than 56 milligrams per deciliter, and in the glargine U300 trials of less than 70 milligrams per deciliter, there was a similar number of events shown in terms of hypoglycemia. So this, it seems again to say, just as you said, insulin is insulin, hypoglycemia is hypoglycemia. So if you have a low blood sugar, no matter whether it's less than 56 or 70, you're going to get a certain number of events, but it's going to be the similar or the same between the degludec and the glargine U300.
But they haven't really been compared directly with each other. This is compared to U100. The relative risk of hypoglycemia is reduced with both these insulins. They've actually, people have done analysis of what it would be if you used the less than 56 with U300.
Right. So if you look at the insulin degludec versus the glargine U100, you see that basically in the degludec arm there was less hypoglycemic events when the blood sugar was at a confirmed blood sugar less than 56, and similarly, as you mentioned earlier, the issue of nocturnal events was significantly less as well. And again, that always is a limiting factor in relationship to our ability to treat patients to their goal. So the other area of insulin management that's also very important is the issues of cardiovascular risk. And if we look at the issues of non-inferiority of insulin, glargine versus standard of care, it appears in the ORIGIN study that there's no difference between insulin, glargine, and standard of care for the issues of myocardial infarction, stroke, cardiovascular death, or heart failure, revascularization, any aspect of the issues that we refer to as cardiovascular related events. And I think that's another important component and something that we're starting to see more and more as an issue in relationship to how we take care of diabetes is the issue and the risk factors associated with cardiovascular risk. And this again was a nice way of proving that there wasn't any difference between insulin, glargine, and other standard of care.
There was some hope at that time that insulin might be better than standard of care. But remember, standard of care is metformin. So starting with metformin in newly diagnosed diabetes. So you got good control, but it wasn't superior, but it was safe.
Right. So that was the other thing. It gave us a lot of confidence in understanding the insulin glargine was a safe and effective
Can that be applied
medication.
To U300?
Yes, it also is applied to
It's
U300.
the same molecule after all.
Exactly. So the FDA concluded with that U300 was essentially the same in relationship to the U100.
To the long-term safety.
Right.
So we can assume that it's safe, just as safe as insulin glargine.
So if we look at the cardiovascular safety of insulin degludec, which was the DEVOTE trial, this was a large trial looking at cardiovascular risk, and they were randomized to a number of different arms of the trial, insulin degludec versus insulin glargine U100. The patients were typical patients with type 2 diabetes, and the trial lasted for two years. And this was a trial to actually look to see whether there was improvement in cardiovascular risk with this agent, insulin degludec. And why don't you tell us a little bit about that safety trial and what it showed?
So, you're comparing insulin glargine with degludec, and in different combinations with different oral agents and sometimes basal bolus therapy, there was no difference in cardiovascular events. So I think, cardiovascularly, they're more or less equal. There was a difference, though, in hypoglycemia. And severe hypoglycemia was significantly less with insulin degludec compared to glargine, and nocturnal severe hypoglycemia was particularly less. Now, in the trial, insulin glargine was given at a fixed time of the day mainly at night. There was some flexibility in degludec, which has been tested in a number of clinical trials. So that might have made a difference in some of the earlier trials to the timing of nocturnal hypoglycemia. If you took it in the daytime, you might have less risk at night. But overall, hypoglycemia was less, and severe hypoglycemia was less. And this difference was statistically significant, perhaps because of the power of the study. This is a longer-term study in a large number of people. Talking of flexibility of dosing, it's been one of the emphasis of degludec was the trials that they did about whether you took it in the morning or you took it at night. It didn't really matter. There's been no dedicated study with flexible dosing with U300, but there are some patients in the EDITION program, EDITION 1 and 2, where they did have some flexibility. Some patients took it at a fixed time, same time each day. Some people were a little flexible, giving themselves a window of maybe 3 hours or so. And there was no difference in terms of A1C lowering, hypoglycemia rates, etc. So I think there is some possibility of flexibility of U300, but it hasn't really been formally tested. In contrast with degludec, there's actually been a randomized trial treating to target and comparing it with glargine given at the same time every day, whereas degludec was given either at a fixed time, which is the same time every day, or a flexible schedule. Sometimes an 8-hour gap between insulins and sometimes up to 40 hours. That can make a difference in terms of a practical thing for patients. Say you are used to taking it every morning, but one morning you forget and you go off to work and you don't know when to take it. You could take it in the evening or you could take it the next morning. And actually, it didn't make that much difference. The A1C reduction was very similar. The fasting glucose was very similar. The hypoglycemia was very similar. So in a formalized, structured manner in a clinical trial, flexible dosing with degludec was possible. So in summary, we have a wide range of insulins now with a lot of different characteristics in terms of pharmacodynamics, pharmacokinetics. You can use it at different times, longer duration of action, less of a peak, differences in hypoglycemia. It gives us a lot of room to individualize even in basal insulin therapy with our patients.
And Vivian, that's what I was going to say, that as a practicing clinician, that's really valuable for our patients because we have a lot of opportunities to really identify and to specifically try to target those particular insulins to the correct patient. And that has given us, that's been a revolution in how we take care of people with type 2 diabetes and type 1 diabetes. It's really been remarkable over the last several years to see that evolution go on forward.